Let's take a look at this CT thorax plain scan of an adult patient presented with hemoptysis as well as weight loss. So you can already spot that there is a speculated lung mass at the posterior segments of the right upper lobe. So further take a look at the characterization part of this lesion, we can appreciate that there is some peripheral lobulated ground glass component, while the central portion of this ground glass opacity having some solid component. So actually what we call a subsolid appearance. And actually it is quite suspicious of underlying malignancy, which is even more chance than pure solid or pure ground glass component. And it is also very classical for adenocarcinoma of the lung having this kind of appearance. If we have some previous CT, initially we may see that most of these lesions are actually starting from just ground glass nodule, and then eventually after several times of follow-up CT, we will start to appreciate there is some sort of component which will gradually increase in size. So actually, speculated border per se is also very suggestive of underlying malignant lesion because it is actually indicative of some invasion to the adjacent parenchyma, and also some transversing air bronchogram is actually supportive of a malignant component as well. So we do not see any other satellite lung nodules at the rest of the lung to suggest intrapulmonary metastasis, but we do see there is something occurring at the posterior aspect of the right lower lobe. So let's take a look at that. Actually, we appreciate that there is some smooth thickening involving the pleura as well as some calcification, but just small amount of effusion. So actually it's a kind of chronic pleural disease, usually with prior causes such as granulomatous infections or hemothorax, something benign. And also actually we can appreciate that the adjacent epipleural fat plane is quite preserved. Okay, so if we have some prior chest radiograph, we may see it's quite static all along. So we can check the previous X-ray and also or even CT to see whether it is persistently similar in appearance and also thickness of the pleural lining to check whether this is really some benign chronic pleural lesion. Since we only have a non-contrast study, so can we assess for any lymph node metastasis? The answer is partially yes and also partially no. For detection of any highlight lymph node, actually we rely on post-contrast study because we will have enhancement of the usual vasculature, while the residual soft tissue will be the highlight lymph node. But it is actually just the same density. Okay, we cannot be able to differentiate them on just a plain study. However, mediastinal lymph node can be well assessed because we have usual fat plane outlining individual lymph nodes, as you can see here. They are not enlarged and also they have some preserved fatty hilum, so they do not have any suspicious appearance, okay, per se in this study. And also most of the CT thorax will also include the upper abdomen. Especially we need to pay attention for any liver metastasis or any adrenal metastasis because they are quite common location of metastasis from CA lung. But you can only see a very well-defined hypotense lesion at the right lobe of liver, which is having fluid density, so very likely it's just a liver cyst only. So how about any bone metastasis? Of course, we can pay attention to individual bones one by one. But one tip that I want to tell of you is that we can pay special attention to the fall position of the vertebra on the axial scan, the posterior aspect of the vertebral body, bilateral pedicles, as well as the posterior element. Because assuming that is the body, transverse process, laminar, and also spinous process, okay, we actually having a circular form of dual venous plexus and having some venous branches during this four portion of the bone. Okay, so assuming we have a tumor emboli traveling within this venous plexus, actually they tend to dislodge at the branching area here. So that's why it is quite famous for us to Also know that we try to see any bony erosion of the pedicles, okay, on radiograph to suggest hematogenous metastasis. But in fact, the posterior aspect of the vertebral body as well as the spinous process are actually very classical as well, okay? So we need to pay extra attention when we scroll through the spine slowly, try to see any bony erosion or any bony lesion as those areas, which is quite suggestive of metastasis. However, we do not see any feature to suggest so in this CT. So apart from doing a dedicated contrast CT thorax, abdomen, and pelvis for further dedicated proper staging of this lesion, eventually we will also need to have tissue diagnosis. Of course, nowadays we also have some blood tests to which aids for the diagnosis as well. But tissue diagnosis is actually very essential. Even we have the blood test because we can do all sorts of immunology staining, further characterization for the prognostic aspect of the lesion. Okay, so if we want to do histology, most of the time we are concerning whether we are doing an endoscopic biopsy or a CT guided biopsy, one approaching from the central portion of the airway or we approaching transcutaneously, okay, from the chest wall. So since this lesion is not near the major bronchi, so actually endoscopic biopsy is quite difficult. So we must do a CT guided biopsy. But how can we do so? Okay, because we have a scapula here, so we try to retract it, okay, ask the patient to have retraction of the scapula, and then we will expect to see the window as the posterior aspect more sizable for us to approach it posteriorly to the lesion. And also what we are aiming for a subsolid lesion is that we aim at the solid component rather than the peripheral ground glass component, because this will give us a high chance to have a better yield to really for the pathologist to make the diagnosis for us.